Hello, my name is Yejin Hong. I'm a medical student in the University of Calgary, and our team is here to explain to you third nerve palsy. Ophthalmology and neurology have a very intricate relationship. The eye is a sensory organ that is very closely linked to the nervous system and is very close to the brain, both in a physical proximity as well as in the sense of the neural pathway. The eye is also innervated by 4 out of the 12 cranial nerves, 2 for detecting light through the optic nerve, and 3 for the extraocular movement using the inferior rectus, superior rectus, medial rectus, inferior oblique, as well as the levator palpebrae superioris in the upper eyelid, 4 for the superior oblique muscle, and 6 for the lateral rectus. The retina also has a neurosensory layer within the series of layers that eventually becomes the optic nerve. As mentioned, third nerve is one of the cranial nerves that link the eye to our nervous system, and this specifically controls various extraocular muscles as well as the constriction of the pupils. There is a condition called third nerve palsy that can occur where the third nerve has been damaged and weakened due to many various etiology. Factors like hemorrhages, cancers, or inflammation can cause third nerve palsy by disrupting the oculomotor nerve anywhere along its path from the midbrain all the way to the orbit. The third nerve palsy is considered complete when all of the branches and all the muscles that it's innervating are affected, and it can also be partial. That means the superior division may be affected, which is concerned with the superior rectus, levator palpebrae superioris, or it can affect just the inferior division as well, which is concerned with medial rectus, inferior oblique, and the parasympathetic fibers. That leads to the constriction of the pupils. And now let's discuss more of the etiologies that can cause third nerve palsy. I apologize, this is a very busy slide, but we'll tackle them one by one. Overall, the palsy can be caused by trauma during birth, and it can also be from a neurological syndrome, infections and tumors, ischemia or the lack of blood flow to the region, or microvascular problems can also cause third nerve palsy. Specifically, there are around 7 regions where a third nerve can be adversely affected, and namely, they are first, nuclear region, as described in our first line there, fascicular, then the uncal herniation and posterior communicating artery aneurysm, both of which go into the subarachnoid space category. The cavernous sinus syndrome occurs in the intracavernous space. The orbital space is also where the third nerve traverses through. And lastly, closer to the eye, the branches of the third nerve, except for the parasympathetic branches, can be affected, also known as pupil-sparing isolated palsy. So largely we'll cover these 4 categories: nuclear, fascicular, subarachnoid space, intracavernous space, and as well as the orbital space. So nuclear space, just because it's so close to the midbrain, rarely occurs in isolation. The most common etiology in this region includes the microvascular infarctions. In the fascicular region, the demyelination is a common cause of the palsy, and vascular and metastatic causes can be factors as well. Fascicular region's abnormalities are known for many possible syndromes. The Benedict syndrome is what the cranial nerve third palsy plus the contralateral hemitremor, hemiballismus, and loss of sensation are collectively called. Contralateral means the hemitremor and the hemiballismus and the loss of sensation occurs on the side of the body opposite to the side where the cranial nerve 3 is experiencing the palsy. Hemitremor, as evident by the term here, means tremor in the half side of the body. Hemiballismus is a violent involuntary limb movements in the half of the body. Now moving on to Naegele's syndrome. This is where third nerve palsy is combined with the ipsilateral cerebellar ataxia and dysmetria. So on the same side where the third nerve has the palsy, there is a lack of coordination of the movement by the legs and the arms. Dysmetria specifically is a form of ataxia that involves overshooting and undershooting with the limbs due to misjudgment of the distance. The Claude syndrome is the combination of the two syndromes that we've talked about. So either side of the body is affected to a certain extent. And lastly, the Weber syndrome describes the third nerve palsy with the contralateral hemiparesis, meaning weakness of half of the body. Moving on to the third categories are subarachnoid space, which includes the uncal herniation or squeezing of the brain's uncal region, causing it to be displaced inferiorly. Aneurysms of the major vessels, such as the posterior communicating artery, can also cause a palsy in the subarachnoid space. In the intracavernous space, some common causes include the cavernous sinus fistula, which is an abnormal connection between the cavernous sinus and the vessels, such as the carotid artery. Aneurysm can also cause it, tumors, and inflammatory events, such as the Tolosa-Hunt syndrome and sarcoidosis. Infections, commonly herpes zoster and TB, as well as pituitary apoplexy. Pupils are usually spared with the etiology in the intracavernous space. And that is important to note because one of the functions of the third nerve is to relay parasympathetic signals to the sphincter muscles in the iris. Lastly, in the orbital space, the neoplasm, trauma, and infections can cause third nerve palsy. Other cranial nerve findings can occur with this etiology, seeing how the cranial nerves are placed so closely together. And because the branches of the third nerve split right before the superior orbital fissure, the etiologies may only affect either the superior or the inferior division. Some symptoms of a third nerve palsy include the binocular diplopia, which is double vision caused by miscoordination of extraocular movements of the two eyes. And the eye turn and pain as well as headaches can also occur. On the same side where the third nerve is affected, there may also be a drooping of the eyelid or ptosis, PTOSIS. This is because a third nerve also innervates the levator palpebrae superioris. That is a muscle in the upper eyelid which elevates the said eyelid upon contraction. Some of the signs or observations that we can make while observing a patient with the third nerve palsy is, as said in the last slide, ptosis. and sometimes ophthalmoplegia in advanced cases, because the third nerve controls all of the extraocular muscles except for the superior oblique and the lateral rectus. That's why the lateral gaze is preserved, because this is controlled by cranial nerve 6. In primary gaze, where the patient is just looking straight ahead, exotropia and hypotropia may be demonstrated because these directions are powered by the lateral rectus and superior oblique, the muscles that are not innervated by third nerve, and therefore they're the only ones not weakened. If the etiology causing the third nerve palsy involves the parasympathetic branch, the third nerve palsy may be accompanied by mid-dilated non-reactive pupil. If there is an abnormal regeneration during the recovery phase of third nerve palsy, the patient may demonstrate lid gaze or pupil gaze dyskinesis. Lid gaze dyskinesis is caused by new fibers from the medial or the inferior rectus connecting to the levator, palpebrae superioris, and therefore upon down gaze or with a deduction, there is the upper lid retraction. Pupil gaze dyskinesis occurs when the inferior rectus or the medial rectus fibers project to the iris sphincter muscles. This will cause pupil constriction on down gaze or with a deduction. Very interesting signs. Some of these presentations can point to other diagnoses. That's why we can't jump to one diagnosis prematurely. Myasthenia gravis is an autoimmune condition with anti-acetylcholine receptor antibodies. This syndrome can also cause diplopia quite early, so we need to rule this out. Thyroid eye disease can also cause proptosis and, in that process, ophthalmoplegia. And CPEO, which stands for chronic progressive external ophthalmoplegia, can also give a similar movement, extraocular movement abnormalities. Some examples include the MERF or Kearns-Sayre syndrome. As with every patient encounter, the history would be the most important aspect to determining the cause and the identity of the disease. Specifically aim to find out when this started to occur, if this is a progressive thing or worsening presentations, and potentially find out what may be causing the supposed palsy. For example, were they involved in a recent trauma or infection? Do they have an inflammatory syndrome? Are there any other neurological syndromes? Then we can examine the eyes with the slit lamp, paying attention to the pupils, lids, and looking for any proptosis, then looking at the motility of the eye. And as for the physical exam in general, we can conduct a thorough neurologic exam with a focus on the cranial nerves 2, 3, 4, and 6. The most important part of the vitals would be blood pressure in this case. Some investigations to confirm third nerve palsy will include fasting blood glucose to exclude diabetes, which can cause hypertension and raise the risk for hemorrhages. Do a CBC and ESR, which is a marker for inflammatory syndromes. VDRL and FTA absorption is done to exclude syphilis, and ANA for autoimmune syndromes. Lumbar puncture can be considered to rule out subarachnoid hemorrhage, looking for those xanthochromia in the 1 milliliter samples. And it can also be used to rule out any infection in the nervous system as well. Myasthenia gravis can be ruled out with the ICE-PAC and the anti-acetylcholine receptor antibody tests. Idrophonium is rarely used nowadays. MR angiography or CT angiography can be considered if the pupils are involved, if they're abnormally dilated and do not respond to light, if there are any other neurological abnormalities, if the pupils are spared but the patients with the presenting third nerve palsy symptoms are less than 50 years of age, if there are signs of aberrant regeneration. So the lid gaze dyskinesis and the pupil gaze dyskinesis, and if there are no improvement of the isolated pupil-sparing microvascular cases after 3 months, such angiographies can be considered. If all these tests are inconclusive, the gold standard is to conduct a digital subtraction angiography. The treatment of third nerve palsy depends on the etiology. If the etiology of the palsy is an isolated pupil-sparing lesions, you could follow if there are any pupil involvement during the first week. This could elucidate to us the potential locations of the palsy, as well as whether the disease is progressive. Occlusion with the transport clear surgical tape can help with diplopia, and if the etiology is found to be aneurysms, tumors, or trauma, we would refer the patients to neurosurgery. Prognosis of third nerve palsy also depends on the etiology. If there are microvascular palsies, we would expect a complete or near complete recovery, and as the etiology becomes more traumatic and compressive lesion-wise, the prognosis worsens. So here is a comprehensive flowchart of everything that we talked about in this video. Feel free to copy and paste this to your notes. Here are the references that we've used to put together this video. Thank you for watching.